Hi, everybody. Thank you for joining us today. Thank you for your time. We are going to be talking today about a whole slew of changes that have happened over the last few months with respect to health benefit plans and prescription drugs. So on our agenda today, first, I'll be kicking things off by talking about the launched last month Trump RX. Then I'll turn it over to John, and he'll talk about the recent ESI settlement with the FTC. And then I'll take back over and John will continue on with actually some changes under the Consolidated Appropriations Act of 2026. And then I will take over and jump in with some different changes under that same law. And then John will finish things off today with the proposed PBM disclosure rules. So let's start out with Trump RX. Trump RX first was its origination happened on May 12th, 2025, when President Trump issued an executive order requiring drug manufacturers to sell drugs in the United States at most favored nation pricing. That is, at prices that are no higher than in other developed countries. This executive order and this mandate was backed by the threat to impose tariffs if companies did not agree. A few months later, in October of 2025, the Trump administration announced the launch of TrumpRx.gov to allow individuals to purchase medications through a direct-to-consumer model. And then in November 2025, we had 5 drug manufacturers agree to most favored nation pricing with respect to certain drugs. And as a result, they received tariff exemptions. The drugs included in vitro fertilization drugs, and also probably most interestingly for people, GLP-1 weight loss drugs. Novo Nordisk put Ozempic and Wegovy within that program. Now, last month, the website went live, but we have lots of questions about TrumpRx.gov and the future. No law provides for TrumpRx. This originated out of the executive order, and the real stick, so to speak, here is President Trump's tariff threats against drug manufacturers. But a few days ago, the Supreme Court decided Learning Resources, Inc. versus Trump, in which the court broadly struck down President Trump's ability to impose tariffs during times of peace. So now we are left with even more questions. Are drug manufacturers going to continue to play ball? Will they continue to add drugs to TrumpRx.gov? As of today, there are 44 drugs on the website. Is Congress going to pay for TrumpRx.gov? Or will a future administration abandon it? With respect to employers and plan sponsors, employers and plan sponsors have not really had much of a direct role yet in TrumpRx. Are they going to be encouraged in the future to steer their employees or their health plan enrollees to TrumpRx.gov? Might plan sponsors start talking about changing the drugs on their formularies that are covered by their health plan if a drug is available on TrumpRx.gov? Another question that we have is the availability of direct-to-consumer drugs through TrumpRx.gov a non-high deductible health plan, which would be considered disqualifying coverage for somebody to contribute to an HSA? We think that the answer to that probably would be no, but we don't know. And then if plan enrollees obtain drugs through TrumpRx.gov, are the plan sponsors, are you all employers, PBMs going to lose important data about the drugs that people are taking? Could people be harmed if they're not obtaining their drugs essentially fully through their health plan? There could be drug-to-drug interactions that are not known, drug-to-disease interactions that are not going to be caught by the vendors if they don't know the the participants' complete profile of prescription drugs that they're taking at a particular time. Another question that comes up is, can employer plan sponsors reimburse their employees for direct-to-consumer purchase drugs? We have some answers from prior guidance from the IRS on this question that could be applicable. So we know that sometimes it's okay. A weight loss program, for example, that's undertaken at a physician's direction to treat a disease would be considered medical care under the Internal Revenue Code, and therefore is generally reimbursable on a tax-favored basis by a plan like a health reimbursement arrangement or a health FSA. But what if it's a drug for cosmetic reasons or the employee's general health or appearance? These, on the other hand, generally are not for medical care and therefore are not reimbursable on a pre-tax favored basis. If employers do decide to become involved with the Trump Rx program, maybe one avenue would be an employer might look to offer an HRA or a health FSA debit card to help employees with cash flow so that they have the debit card available to purchase the drug from trumprx.gov. But something to keep in mind is HRAs and health FSAs, debit card is great and easy for the participant, but they do still need to submit receipts for substantiation. Another question, will direct-to-consumer pricing and trumprx.gov impact employer plan sponsors' relationship with its other vendors, its pharmacy benefit manager, its TPA, or an insurer? Lots of times, contracts with PBMs and TPAs have exclusivity clauses and might require the employer or the plan sponsor to only use that vendor for the prescription drug services. Would that prevent the employer interacting in some way with trumprx.gov? Given that right now we only have 44 drugs on the website out of the thousands and thousands of drugs that are approved by the FDA, this might not have an immediate impact. It might take some time, but could it change over time? How many years? Are entities going to be willing to bet on trumprx.gov, continuing to be practically viable? Will drug manufacturers continue to participate? Or, like I mentioned before, would it be looking at being abandoned in a couple of years? Something else that individuals often have questions about is, will their health plan provide credits toward their deductible and their maximum out-of-pocket limits for drugs that they purchase on trumprx.gov? The answer right now is probably not. But people might start asking for that. And also, the federal government's been thinking about it too. So the FTC and the ESI settlement just addresses this very question, actually. And the settlement requires that ESI include as part of a standard offering that members receive benefit of direct-to-consumer pricing through the Trump Rx program, and count member payments made through Trump Rx towards their deductibles and their out-of-pocket cost. Interestingly, trumprx.gov also has some terms on this. So on trumprx.gov, in order to obtain a drug at the low price, it's set up as a coupon model. And in order to obtain the coupon, you have to agree to some terms and conditions. And for example, the Wegovy pill, which is very prominent on the trumprx.gov website, one of the terms is that you agree not to count the cost of prescriptions towards your deductible or your true out-of-pocket. So there's some things to be worked out here. We also are wondering if the FTC and the ESI settlement might be a way for the federal government to try to get Trump Rx to be the exclusive method of direct-to-consumer pricing between drug manufacturers and consumers. But again, the coupon terms on TrumpRx have varying terms um, about counting the cost of prescriptions toward the deductible, but also about whether submission of through commercial plans or employer-sponsored plans is okay. And I'll address that in a future slide, but there are dozens of drugs on the website, 44, and the terms for each drug can vary from day to day. So another big question is if employers will become involved with TrumpRx.gov, who's going to be monitoring those terms? Another question, how will employers accomplish interaction with TrumpRx.gov? We've already seen one healthcare company step in and expand, shift from direct to consumer pricing to direct to employer pricing. In November, Waltz Health announced an agreement with Eli Lilly and Novo Nordisk, which has those GLP-1 drugs, for the direct to employer pricing. Waltz Health would act generally like a PBM and perform certain PBM functions. Would the big market players in the PBM world view this approach as a threat? And are they considering offering similar services, similar programs? But are employers going to be interested in this? Or is this going to be too niche because it's going to be a limited number of drugs that are available, even though they already include popular GLP-1 drugs? Are brokers and benefit advisors going to be incentivized to push these products? What will their compensation look like with respect to these? And then again, thinking about contract terms, if an employer today went to Waltz Health and signed up for their program, would they be in violation of their contract with their PBM or their TPA or their insurer? Is there an exclusivity clause that could have pretty severe consequences? Like, would the employer potentially lose some or all of their rebates? Could that trigger a right for the PBM or the TPA to renegotiate their whole contract? This definitely warrants caution moving forward with these types of direct to employer programs. So to obtain coupons on TrumpRx.gov, you have to agree to conditions. Some of them are okay. Some drugs on TrumpRx.gov permit patients using TrumpRx.gov while they also have commercial insurance, employer-sponsored health plans, or perhaps a plan off the individual market. Other drugs are not okay with that. So, for example, Duavi prohibits patients that are enrolled in commercial insurance plans. They can't submit any claims for reimbursement for drugs that are purchased from TrumpRx.gov. And if a plan reimburses somebody for the cost of a drug from TrumpRx.gov, when the terms say they shouldn't, is that plan, and by extension, the plan sponsor employer, causing the patient to violate those terms? Could that be considered tortious interference with the contract? There's risks there. There's lawsuits have been filed over these questions in slightly different contexts. So then how will plans or their service providers track the terms? And what if they change over time? This is definitely has some administrative burden to it. And with that, I'm going to turn it over to John now, and he will talk about the FTC settlement with ESI, which is a really very interesting settlement that the FTC reached that dictates business terms for ESI with respect to employer plan sponsors. All right, go ahead, John.
All right, sounds good. Thanks, Katie. Just going to try to share my screen real quick here. Let's see here. Sorry about that. All right. So in terms of this FTC settlement here with ESI, and thanks everyone for joining us too, by the way. Couple interesting things going on here. Many of you may have heard about this recent settlement where a few months ago, the big three PBMs, which control about 80% of the prescription drug market, ESI, Optum Rx, and CVS Caremark, were sued by the Federal Trade Commission, the FTC, over insulin pricing issues. So, kind of a narrow, sort of discrete issue. But what has happened is that as the FTC and the three PBMs have negotiated about trying to settle that insulin pricing matter, it turns out that the FTC had a slightly different goal in mind, sort of almost trying to remake the entire PBM industry. In other words, it seems like FTC said, hey, we have a little bit of leverage here. Let's push the leverage with respect to trying to get the three big PBMs to modify some of their business practices. So about a month ago, ESI and FTC reached a proposed settlement. Optum Rx and CVS are still negotiating. There was a court filing from just a few days ago where the parties noted that they're making progress on the resolution. So it looks like the settlement is moving along here. So that technically what we're talking about here only applies to ESI, but in the back of your mind, I think you should think of, this could likely apply soon, or similar terms likely could apply to Optum Rx and CVS. And even if you don't use one of those PBMs, I assume that plan sponsors, their consultants, their PBM consultants will look at these terms and say, hey, maybe some of these terms should apply to other PBMs too, not just the big three. I could see that happening. So again, we'll see where that sort of shakes out. But the ESI settlement does have interesting terms, again, kind of far beyond the insulin. For example, ESI has to provide a standard offering to plan sponsors. So the standard offering is sort of a default where the federal government is saying to ESI, this is the typical terms you have to offer to employers and other plan sponsors. It looks like the parties can still negotiate around that. So if a plan sponsor, for example, is unhappy with that standard offering, it looks like you can still kind of renegotiate some of the terms. But I think the default plan standard offering terms are supposed to be favorable to plan sponsors. We'll see how it shakes out. But in terms of what those standard offerings are, let's walk through them. They talk about a wholesale acquisition cost or WAC, and drugs in general can be sometimes fall in the high WAC category where they're made from expensive drugs, kind of the underlying ingredients, or low WAC drugs. And basically, PBMs can sometimes have a choice of which drug they are going to steer your enrollees and you as the plan sponsor to have. And in the past, ESI, I think, has been accused, I guess, of trying to steer folks to kind of the higher WAC cost drugs. And so I think the federal government in the settlement is saying, hey, ESI, you can't do that. You have to have a standard formulary which sort of steers the plan sponsors and the enrollees to the low WAC drugs. Again, seems to be an effort to force that kind of cost savings there. In addition, the enrollee's out-of-pocket cost must be based on the net unit cost of the drug. So they seem to be requiring that certain rebates, discounts, things like that be taken into account also. ESI must provide full access to programs like patient assistance programs that reduce costs. As noted, as Katie noted in the prior slides, ESI has to ensure that the standard offering kind of integrates with TrumpRx.gov. Members receiving the benefit of the direct-to-consumer pricing through the TrumpRx platform. Member payments made through the TrumpRx platform must count towards their deductibles and out-of-pocket cost maximum accumulators. Let me just pause and kind of reemphasize this. I know Katie raised it a little bit before. I'm not sure. I'm mystified when I think about this in terms of how is this going to work in the real world? Because when you go to the TrumpRx.gov website, and it's interesting, you should go there and check it out if you haven't done so in the past. Basically, it kind of steers you to buy the drugs directly through the manufacturers or in some other ways. In other words, you are not providing a credit card to TrumpRx.gov and purchasing drugs through TrumpRx.gov. So the individuals are kind of routed, say, to the drug manufacturer's website, and then that's where you buy it there. So what does this mean? I mean, it means that basically there's no central repository, keeping track of this information. So if I'm an enrollee in the Reinhardt Health Plan, and if I go to the TrumpRx.gov website and I buy a drug through it, Reinhardt is not going to know that. Our PBM is not going to know it. Our TPA is not going to know it unless perhaps I give them that information. So that begs the question of, if ESI here has to count these payments that I'm making towards my deductible out-of-pocket cost maximum accumulators, but if I don't tell ESI that, how does ESI comply with that? I don't know. Maybe there's some other provision which is not in the settlement yet, which is going to say to the extent that the member actually tells you that. That would be kind of logical, but it's not in there right now. So again, open issue in terms of just kind of a nuts and bolts kind of, well, how does this actually work type of question. Rebates have to be provided at point of sale to enrollees. And let's just pause for a second here. So, a lot of times, rebates right now are not provided on a point of sale basis to plan enrollees. So, if I buy a $1,000 drug, the plan sponsor may get a $200 rebate, but that $200 rebate isn't necessarily provided to me right away. So I still paid the 1,000 as opposed to paying, say, $800 if I'd gotten the $200 right away. Instead, the rebates kind of accumulate over time and they kind of slowly get paid back to the plan sponsor in bulk at the end of the year or within 90 days or 180 days after the end of the plan year. It can take a while for rebates to come in. And so now, if those rebates have to be provided at point of sale, what we could see is the plan sponsors get a loss of rebates instead of getting a huge, rebate dividend, millions of dollars at the end of the year, after the end of the year. Suddenly they don't get any rebate, or they get a very small rebate at the end of the year. And that rebate is generally, going to be some kind of plan asset, or at least portions of it would be a plan asset. It can only be used in certain ways, maybe to provide benefits or reduce costs. And now, if they don't get that giant rebate at the end of the year or 90 days after the end of the year, do they have to increase premiums? I don't know. So we're going to see how that'll work, but I think they will impact how plan sponsors approach kind of pricing issues there. In addition, ESI cannot guarantee compensation to plan sponsors, so no guarantee of compensation. No spread pricing. Many of you know that many PBMs do engage in this kind of spread pricing, where the drug may cost $30, but the PBM charges the employer $40 and keeps that $10 spread. This change, I think, is a pretty big one, or at least it could be a pretty big one for some plan sponsors. Some plan sponsors have already kind of gone with other PBMs who don't have spread pricing, or they have worked with some of the big PBMs to kind of minimize that cost impact. And so, again, we'll see how that works out. The cost here, though, the effective date here is as soon as commercially feasible, but no later than January 1, 2028. I'm going to be interested to see what ESI is going to do. If they're going to lose millions or billions of dollars in revenue, are they going to try and offset that? Are they going to increase administrative fees, some other fees? Again, to be determined, I believe. ESI is going to have to provide additional automated reporting for plan sponsors, including an annual report disclosing each drug product's costs and pharmacy claim level reporting. That's interesting, but as we'll talk about, as Katie and I will talk about, under the proposed regs in the CA 2026, there's additional obligations that kind of go beyond that. So, is this important? It kind of depends upon how ESI interprets this particular settlement and what exactly is required. So, again, we've got now three different disclosure rules going on here with regard to this kind of pharmacy claim level reporting. Those are going to have to be harmonized, I think. Plan has to receive any data needed for the transparency and coverage regulations, the TIC regulations that you may have heard about. ESI has to disclose the compensation paid to consultants or brokers in connection with the pharmacy benefit, and must disclose to each plan sponsor any such compensation paid. So again, kind of more additional, peeling back the onion or whatever kind of phrase you want to use, of kind of revealing some of the layers of compensation that occur typically in the health and welfare plan space. Other changes in the ESI settlement, group purchasing organizations have to be onshored by July of 2028. You may say, what's a group purchasing organization? It is not an organization that you may be in. Sometimes employers kind of band together through cooperatives to get better deals. That's not what is going on here. Instead, what's going on here is the three big PBMs have offshored into other countries some arrangements or some entities that they have, and then those entities negotiate with the big drug manufacturers. And then those contracts can kind of be hidden because they're kept overseas. The profits can be kept overseas and not taxed in the United States, is my understanding. And so again, the whole GPO onshoring here, I think, is intended to make it easier to obtain information about those contracts. And I assume from the federal government's perspective, it may become taxable, which they may find appealing here too. Do want to note too that again, some of these have varying effective dates, and so some of these I think are, as soon as practical. Others are 2027, others are 2028. So, there's a whole bunch of different moving dates going on here. But I think the point to note for plan sponsors is you should ponder whether some of these changes are helpful to you and whether if you accelerated the time period here, would that be helpful to you? So, you know, if you use ESI right now and you look at this and say, boy, I really like that low whack change. Could we get that in effect here in 2026? Could it be 1/1/2027? Can you kind of move up the effective date by contract, even if the settlement requires a later effective date? And I don't know, by the way, what ESI or any of these other PBMs like Optimus and CVS are going to say to that kind of request. I know we've had some discussions with plan sponsors. I know that they're talking to the vendors about that, but I don't know how the vendors are really going to react. These are big changes, and so it could take a while for them to implement them as a practical matter. All right. Let me just jump ahead here to the CAA 2026 changes because these are also important changes. So again, we're moving into our third big topic here. There's a lot to going on, and again, a lot of overlap here. So just know that we're not trying to, confuse anybody, but there's a lot of overlap. Again, some of those disclosure rules that we just talked about that ESI has to agree to, and presumably Optum and Caremark are going to have to agree to soon. Some of those disclosure requirements really tie into and overlap with the CAA 2026 disclosure rules and the proposed regulations. So again, there is a lot going on, unfortunately. All right, so what is going on here? February 3rd, 2026, President Trump signed into law the Consolidated Appropriations Act 2026. You may have heard about this. This was part of the federal government funding bill. And although this has really nothing to do with federal government funding, it got stuck in there as part of this sort of must-pass legislation. CA 2026 provides for very important changes for prescription drug plans, PBMs, plan sponsors, TPAs, brokers, and others. There's really two main pieces. You should kind of think about it as new restrictions on PBMs really specifically. So those PBM restrictions really don't directly apply to other health and welfare plan vendors. So really don't apply to dental plans. TPAs can be impacted to the extent that they are processing prescription drug claims, and sometimes they do with regard to entities or drugs that are provided in a hospital setting that may be more on the TPA side of things. So TPAs can be impacted here a little bit too, but really the heart of this new piece are these PBM rules. In addition, there's some new prohibited transaction rules that apply to a variety of health plan vendors, not just TPAs, not just PBMs. So that is a way more expansive piece that we will be getting into here. In terms of these new restrictions on PBMs, PBMs, as many of you know, have sometimes been critiqued for kind of opaque reimbursement models. They don't tend to operate just on a pure per employee per month administrative fee basis. They may have that. I've seen some contracts where it's a negative amount where the PBM is actually paying the plan sponsor like $1 per member per month for the right to provide these services. You may say, well, how can you pay money? How can you lose $1 per member per month in an administrative fee setting? The answer is they're not losing $1 per member per month overall. They may be giving you a $1 per month credit, but then they make money on the back end through rebates, through spread pricing, things like that. So again, but that has tended to be kind of opaque, harder to determine, things like that. So CA 2026 is an effort to change or maybe eliminate that type of opaque reimbursement model, but in sort of a strange kind of roundabout way. So instead of just saying, PBMs, you can't do this, what they're doing is they're saying the contract between the plan sponsor and the PBM can't allow the PBM to do it. So they're kind of forcing plan sponsors, employers to be the ones who lead the charge. You're the ones who are jousting against the PBMs and making sure that those contracts don't contain these terms. Again, kind of strange. It's sort of a odd roundabout way of doing it. It is not unprecedented, though. If you recall, the CA 2021 has a gag clause rule. That gag clause rule requires that certain information be provided back to the plan sponsor. How is that enforced? Basically, it's the same structure. The federal government said, plan sponsors, you cannot have a gag clause term in a contract. If you do, then you, plan sponsor, are violating the law. So again, the overall goal is to impact the plan vendors under the gag clause rule, but they do it in kind of a roundabout way by forcing the employers and plan sponsors to take the lead in accomplishing that policy goal. In terms of the effective dates, two very important effective dates here. Most of these new PBM restrictions apply for the first plan year on or after 30 months from the date the CAA was enacted. So I just told you it was February of 2026 when it was enacted. If you jump forward 30 months, about 2.5 years, basically a plan year starting on and after August 1, 2028. So if your calendar year plan, this is a January 1, 2029 change in terms of some of these disclosure rules. So that is kind of far out, really. 2029 seems like forever from now. It'll come up quickly, but the more important one is these ERISA prohibited transaction rules. Normally, when Congress enacts a big law like this, they have this kind of delayed effective date. Congress did not include a delayed effective date for these ERISA prohibited transaction rules. So if you have an ERISA covered plan, and most clients have ERISA covered plans, but we work with some church plans that are non-ERISA. We work with a lot of governmental plans that are non-ERISA. So they will not be impacted by these particular ERISA prohibited transaction rules, at least not directly impacted. We've talked to some clients about, if you're non-ERISA, should you try to force the vendors to comply with these rules, even though they don't technically apply at all. So again, there's some moving pieces even in that general discussion. All right, so, but let's focus on the new rules, which again are more of 2028, 2029. So you have kind of a feel for what's coming down the pike here. So again, these new disclosure rules not directly applicable today, unless you try to force them by contract to be applicable today. These are more 2028, 2029. What do we have? First of all, we have a new PBM disclosure report. Every 6 months or every 3 months, if the plan and the PBM agree, the PBM must provide to the plan a plain language, machine readable report, which has a whole bunch of information in it, a lot of information, more information than you probably have ever seen with respect to your prescription drug plan. Technically, the report kind of varies a little bit depending on whether you're a specified large employer or specified large plan. We're not going to worry too much about that distinction here. The cutoff is like 100 employees, so most employers who have self-funded plans, I think, are going to fall into this category of you're going to get the information. In terms of what you're going to receive, let's kind of tick through it here. First of all, a drug list, a list of drugs for which a claim was filed. Compensation, the contracted compensation paid by the plan for those drugs to the PBM. And then the contracted compensation paid to the pharmacy by the PBM and the difference between the two. So let's pause for a second here. So if a PBM charges $100 for drug ABC, but only pays the pharmacy $60, the $40 spread is now visible. That's what this new rule is saying, is that PBM, you're going to report to the plan sponsor, we charge you $100, we only paid out 60, we kept $40 as profit, is what this new report is going to detail. Drug detail, the name of the drug, the dosage unit, the wholesale acquisition cost, that WAC cost that we talked about before, listed as cost per day's supply and cost per dosage unit on the date that the drug was dispensed. Let's pause for a second here. So these drug prices are notorious for varying. They can change multiple times per day in terms of what the drug cost is. So in other words, the cost that you as the plan are paying on Tuesday may be different than the cost that you as the plan are paying on Wednesday for that same drug, maybe the same enrollee or different enrollee. So that's in part why it gets a little bit confusing here in terms of this drug detail. So again, I think that the intention is to sort of flood the plan sponsors with information, and then the plan sponsors will probably use some kind of consultants to try to parse through the data here and try and interpret it and say, okay, here's the trend, here's what we're seeing in terms of the costs, things like that. Total number of prescription claims has to be included. A drug pricing detail, net price per course of treatment or single fill after rebates, fees, alternative discounts, or other remuneration is received from applicable entities. Applicable entities, basically drug manufacturers. That's what they mean by that term. I do have some questions about this. For example, per course of treatment, how will a PBM know if a course of treatment is over? How do they get that information? As I mentioned before, it can take months for rebates to actually show up, and months of not maybe half a year or so. How will a PBM be able to timely provide this information in the report if they don't get access to those rebates for a long period of time? Enrollee spending, total amount of out-of-pocket spending by enrollees on the drug, including spending through copayments, coinsurance, and deductibles, but not including drugs which are excluded. Total net spending, the plan spending, the total amount received or expected to be received by the plan from the applicable entities, the drug manufacturers, and rebates, fees, alternative discounts, other remuneration. So basically what the plan receives in rebates. And again, just pause for a second here. Is the plan really going to know that? Will the PBM know that? I assume it's going to take some, estimation by the PBM to come up with kind of accurate data there. The rebates which are received, the total amount received or expected to be received, again, actually received pretty easy for them to calculate, I would think. Expected to be received, probably a little bit more difficult. They don't necessarily know how many of your enrollees are going to be taking which drugs in the future. So again, it's sort of an estimate of what the PBM is going to be receiving in rebates. The PBM also has to disclose, to the extent feasible, information on the total amount of remuneration for such drug, again, taking into account the participant contributions and the different rebate amounts there too. Then the PBM has to tell you, the plan sponsor, the effect of the rebates on drug spending for each therapeutic class. So for each kind of therapeutic class of drug that treats a particular condition, there's this new kind of separate report, which now the PBMs have to provide, talking about the total gross spending on drugs in each such therapeutic class before rebates, price concessions, alternative discounts, etc., the net spending after the rebates, and the total amount received by the PBM from such rebates. So again, kind of a therapeutic class disclosure report, different than the other report I was just talking about. Next, PBMs have to provide a breakdown of higher cost drugs. So for certain higher cost drugs, generally that exceed $10,000 during the reporting period, which again is either 6 months or 3 months, depending upon how it's negotiated, the list of the other drugs in that class and the rationale for the formulary placement of such drugs. Let's pause for a second there. What do I think is going on? I think what's happening here is the federal government is saying, hey, for some of these high cost drugs, the PBMs may be a little bit biased and may try and put certain drugs on the formulary on the basis of them getting additional rebates. So if there's a couple different option drugs out there that'll treat a medical condition, but a PBM gets $1,000 rebate on one, a $100 rebate on another. Is the PBM biased in favor of the one where it gets $1,000 rebate as opposed to a $100 rebate? So that's really what's going on, I think, here with regard to the higher cost drugs. In addition, the regulation kind of, or the CA 2026 specifically contemplates that the PBMs will have other kind of related entities, affiliated pharmacies, folks like that. And if they do, that they have to disclose the mandatory mail and specialty home delivery programs, any kind of refill assistance, auto refill programs, any kind of benefit design parameters that encourage or require participants to get those prescriptions through the affiliated entity. Again, what's going on here is many of the big PBMs have their own, say, mail order program, and they try to steer enrollees to use their mail order program as opposed to going to a different kind of competing entity. And so again, this will be kind of more specific disclosure about that type of situation. Um, in addition, there's going to be a summary of all this information going to the plan sponsor. So again, a lot of detail, and now it's kind of a summary of that detail. The summary document is going to go to the group health plan from the PBM with a lot of this information. The goal of this summary document is to provide information that a plan sponsor would need that it would find useful for purposes of selecting a PBM. So if you were to take it out to bid, if you were to try to find a replacement PBM, what information would you want, like estimated net cost, cost per claim, fee structure, reimbursement model, things like that. So it'll be helpful for a plan sponsor, but putting on our lawyer hat here, it also makes me a little bit nervous because now it'll be kind of documented to the plan sponsor. Okay, here's your current PBM, here's what their costs are. It's kind of black and white. And if you don't do anything with that information, are you subjecting yourself to a fiduciary risk? Because let's suppose that, unbeknownst to you, because you never bothered to look, there were a whole bunch of other PBMs who would have provided better black and white numbers. And if you just sit on it and don't take any action, you have additional fiduciary risk is our concern there. In addition to the summary of information to the plan sponsor, there's a new summary of information to the plan enrollee. And basically, the PBM is going to provide a summary document for plans to provide to participants that contains a lot of this information. That summary document is going to state that the enrollees may request specific claims level information required to be furnished under CA 2026. I'm assuming that that claims level information is specific to one enrollee. In other words, if I participate in the Reinhardt prescription drug plan, John, can see John's claims. I assume I don't get to see Katie Cratch's claims, for example. That wouldn't make a lot of sense to me. But so we'll see where that goes. I think that'll have to be clarified in future regulations. This report to the plan enrollee is also going to include the total net spending by the plan or coverage for all such drugs, including the total amount of rebates, fees, alternative discounts, and other remuneration. So again, kind of shining a light and making it very clear to the plan enrollees what is going on here with regard to the prescription drug plan. And again, this is really specific to PBMs, not to TPAs, not to other vendors, in terms of what the specific rule is really kind of talking about here. The report is also going to include other general information, total net spending by the plan for all such drugs, any amounts paid directly or indirectly in rebates for fees or other types of compensation to brokerage firms, brokers, consultants, advisors, or any other individual with regard to referring business to an entity providing PBM services or considering the entity for providing PBM services. Again, what's going on here in kind of plain English? What I think is going on here is if you have followed some of the lawsuits that have been percolating up in the health plan space, some of the plaintiffs' lawyers are making allegations that the brokers are receiving payments behind the scenes that the plan sponsors don't know about, and that the brokers therefore maybe are conflicted, that they have kind of a hidden bias to steer plan sponsors particular ways to particular vendors. I don't know if those have really been proven yet. Those lawsuits have not been particularly successful, but the federal government, I think, is worried enough about that sort of, behind the scenes, compensation paid to brokers, consultants, et cetera, that they're now trying to shine a light in terms of those additional fees that may be going on there. Again, probably from a plan sponsor perspective, very helpful, very good to, kind of peel back the layers of the onion here. But it also, I think, from a lawyer perspective, kind of a double-edged sword for plan sponsors. Again, right now, it's difficult for plan sponsors to get access to this information. Therefore, it's difficult for plan sponsors to be held liable for it. It's difficult for plaintiffs' lawyers to find it. It's difficult for the DOL to find it. Once we have all these details, again, will it be easier for plan enrollees to find out, enrollee attorneys, Department of Labor, things like that. So you can kind of see how plan sponsors want this information, but then they don't want it to be used against them. So that's the kind of legal concern, I guess. The report from the PBM has to follow the HIPAA privacy rules, generally must contain summary health information, not protected health information. The plan sponsor does have to follow HIPAA's restrictions. So, to the extent that something is identifiable, you do have to follow the HIPAA rules, including its firewall requirements. That should be fine, I think, as a practical matter. There's also a new written notice requirement. Each plan year, the plan has to provide each participant or beneficiary written notice informing them of the requirement for the PBM to submit reports to the group health plans. It looks like you'll probably be able to just include a notice in the SPD as opposed to an annual mailing to the plan enrollees. That's how we're kind of reading it right now. But again, we'll see when the regulations come out. Disclosures to business associates. There's going to be a lot of information that is going to be flowing to the plan sponsors. Plan sponsors are going to want to, again, probably have some kind of like consultant, PBM consultant, take a look at a lot of this data. Can they do that? The answer is, I think, probably. There's some weird language in the CA 2026 saying that if a plan receives a report under the prior section, it can disclose such information only to the entity from which the report was received. That's kind of strange. That's the PBM. So I think they're saying if the PBM sends you a report, you can only send it back to the PBM. Why would you send it back to the PBM? The PBM just gave you that same report. So that first sentence actually doesn't make any sense to me. But then the second sentence says, or as permitted by the HIPAA privacy regulations. So HIPAA privacy regulations would say, yeah, you can disclose PHI to your business associates, like consultants, attorneys, folks like that. So that's, I think, what is going on. So I think you will be able to disclose it to your plan vendors. In terms of public disclosure, it is possible for the PBM and the plan sponsor to agree to reasonable restrictions on the public disclosure of the information contained in one of these reports. So again, who is the public? I think is not really defined. I assume it's really truly the public. Any random person in the world is what I think they mean, but we're not quite sure about that. The Department of Labor is supposed to provide standard formats for these reports by about August of 2027 and issue regulations at that same time. So again, more to come here in about 17 months or so. In addition, there's also a new disclosure rule from the plan to the enrollee. Plan shall provide to the enrollee the summary document noted above and certain claims level information related to the difference between the contracted compensation paid by the plan to the PBM versus the contracted compensation paid to the pharmacy. So again, that kind of spread pricing. So again, plan sponsors are directly impacted by this. You're going to have to ensure that your enrollees get this information. I don't know if plan sponsors will ask the PBM to do that on their behalf or if plan sponsors will take on that obligation. But again, there is a new plan sponsor reporting requirement here. Enforcement. Unfortunately, these rules do have enforcement provisions. Unusually, they actually apply directly to the PBMs, which is unusual. I know that in the past, most of these rules have applied to the plan fiduciaries, the plan administrators. Now, the enforcement rules actually apply directly still to the plan fiduciaries, but also to the PBMs too. In terms of the penalties, these are potentially very large penalties. And again, they're brand new penalties. $10,000 for each day during which the plan fails to provide the required information. One quick question. I don't know if $10,000 per day means 10,000 per day per enrollee or just 10,000 total. I think that needs to be clarified. False information. If a PBM or third-party administrator providing services on behalf of the issuer knowingly provides false information, the penalty is $100,000 for each item of false information. I'm not quite sure what an item is, but you just heard me tick through a whole bunch of different things which have to be included in these reports. Are each of them a separate item? I'm guessing that the answer is yes. And so if it's false and if it's knowingly false, I mean, you're talking about, very quickly millions, of dollars, maybe more worth of possible penalties. So again, kind of very large dollar amounts are possible in that situation. There is some way that the penalties can be kind of waived and reduced there too. Whew, and that is kind of a lot. So I think we're going to turn it back over to Katie here for her to jump back in.
All right, thanks, John. Yeah, I know everybody here. This is like John mentioned before. We have a lot of things, a lot of pieces of guidance and legislation that happened in a very short window of time here, and looking at effective dates ranging, as I'm about to talk about, from arguably now to through 2029. This is something that I think employers and plan sponsors are going to need continuing guidance about, and frankly, help with tracking to make sure that everything that needs to be done is getting done, and that therefore, risks associated with not doing those things are being mitigated. But now I'm going to turn over to, like I mentioned, something that we think is applicable right now as a result of the Consolidated Appropriations Act 2026. So CAA 2026 has provisions, like John mentioned, for ERISA covered plans. We're not talking about governmental plans that are not subject to ERISA. We're not talking about plans that are sponsored by churches or church affiliated organizations that are not subject to ERISA. But with the widespread wholesale changes that are going to be happening in the PBM market, we anticipate that sponsors of those plans might have some bargaining power to also ask for this information and put themselves in a better position. So the Consolidated Appropriations Act 2026, it modified ERISA, what are called prohibited transaction rules. These are rules that just flat out prohibit certain types of conduct. And then, so within a big general flat out prohibition, there might be a carve out exception to allow some type of action. And these rules now expand when service providers, entities that provide services to health plans, need to disclose their direct and indirect compensation. And it's the responsibility of a plan fiduciary, the responsible plan fiduciary, quote unquote, needs to obtain disclosure from the covered service provider, another term of art, before entering into extending or renewing the contract with that service provider. So who is a covered service provider? That's a service provider that is going to be entering into a contract with the covered plan. Covered plan is essentially a health plan. Could be dental, prescription drug, medical, vision, those sorts of services, and reasonably expects to receive $1,000. And that number is adjusted annually. So that's a wide net. Under the CAA 2021, that list of service providers was previously limited to entities that provide brokerage services, so basically brokers, and consulting services linked to these health plans. Now, CAA 2026 has gone ahead and greatly expanded the list of service providers that are covered service providers. The list now includes services, including brokerage services, that are related to a long list of activities that will be on the next two slides, and as well as an open-ended other services, not just consulting services. So these services encompass virtually all types of services that a group health plan might need to operate. So they include services relating to plan design. How should you design your plan? Services related to insurance selection, including dental and vision, record keeping, medical management, administration, stop loss insurance, PBM services, and wellness design and management services for wellness programs. Transparency tools. These could be tools related to transparency and coverage requirements. They could be tools related to other transparency requirements. Um, John talked about group purchasing organizations previously. Um, those would also be captured by here to the extent a plan sponsor would ever have a contract or a group purchasing organization agreement. Uh, Preferred vendor panels, disease management, similar to wellness plans or wellness programs, compliance services. So here I'm thinking, obviously attorneys provide compliance services, but also the Department of Labor has had a big initiative over the last few years to uh, increase the cybersecurity with respect to health plan data. And so health plan sponsors have been, in efforts to improve their cybersecurity, hiring cybersecurity consultants. Those might be captured under compliance services, employee assistance programs, TPA services, or consulting relating to any of these things. So that's really like a very long list. That's, like I said, virtually any type of service provider that might be needed to run a group health plan. Uh, what, how broad could we be talking here? So say you ask your trustee employee benefits attorney about a particular plan design. You want to exclude GLP-1s, and you want to know what you can do about that and how to achieve it. Your lawyer provides you with advice on this topic and sends you a bill for over $1,000. Is the lawyer captured as a covered service provider under this rule? Uh, I know the position that Reinhardt is taking is that we're going to be very, we want to provide disclosures. We don't want to make our clients non-compliant, but it's a question that maybe other law firms might have a different take on. And with respect, this is the provision. This is the part that really made our attorney eyes pop a little bit. When was this change with respect to all of these service providers effective? There is nothing in the statutory language that indicates a delayed effective date with respect to these changes. And the general rule is that unless a law indicates a delayed effective date, the law is effective as of the date it was enacted. So that was February 3rd, 2026. It is a little bit interesting because the headings within the law frame these changes as clarification of covered service provider. Frankly, that's a little bit disingenuous. These are we're expanding from brokerage services and consulting services to that whole list of services that I just told you about. But putting that aside, unless we get some sort of guidance indicating it, that there's some sort of delay with respect to these provisions, we've been proceeding as if they are effective now. And that means that there is work to be done now with respect to contracts that are being negotiated and contracts that may be up for renewal. We've been advising clients to be asking for disclosures with respect to those contracts. So you'll remember that under the CAA 2026, John mentioned that the general effective date was 30 months later, putting it at approximately August of 2028. So if you have a calendar year plan year, January 1, 2029. This list of changes is subject to that effective date. There's a whole list of changes also within the prohibited transaction rules the rules for ERISA plans that say you need to do X, Y, and Z. Otherwise, you are engaging in a prohibited transaction. Um, and as part of that, contracts with a service provider for pharmacy benefit manager services need to contain more terms. First of all, it has to provide for 100% pass through of rebates. Um, however that word rebates is framed, rebates, fees, alternative discount, money, basically received from a drug manufacturer, or applicable entity could be wider than drug manufacturer in this context. Interestingly, if it's contract, requires that these rebates be related to utilization of drugs and drug spending under the plan. So, to the extent that a PBM can still squeak by using spread pricing revenue, this provision would not apply at this time. These 100% of rebates pass through. The law says they need to be remitted to the group health plan. And for us lawyers, that raises some questions. Do they really need to go to the group health plan, not the plan sponsor, the employer? If these amounts are going to the group health plan, is that creating ERISA plan assets, which are subject to a whole host of restrictions and requirements? Might that cause your group health plan that previously was considered unfunded to become funded? And, as a result, bring in Form 5500 filing obligations that weren't there before. There's some questions about this that we are hoping that guidance will clarify, or at the very least, would be addressed in regulations. Again, these must be remitted on a quarterly basis to the plan, or if you have a policy that's fully insured, within 90 days after the end of the quarter. And the law notes that if the contracts will need to say if there's an underpayment for a prior quarter, it must be remitted as soon as practicable, but not later than 90 days after the notice of payment is first given. It's not clear in this section who is actually providing the notice of underpayment. Is that going to be a PBM raising its hand and saying, "Our bad, we need to give you this additional money," or would it be from the plan sponsor? We'll have to see. Another requirement is that the contracts require the rebates to be fully disclosed and enumerated to the group health plan. But what level of detail are we talking about here with respect to enumeration? That could be an extremely long list of details. If we go drug by drug. If an excess payment is made to the plan sponsor, that has to be returned back to the PBM, the service provider. That's an interesting requirement because an excess payment is made to the plan sponsor and it becomes plan assets. Potentially, if it's put into a trust, how is that money going to be returned back to the service provider? And I want to note here that the DOL is empowered to issue regulations with respect to the procedures for this remittance of rebates, audits, timing, and how the disclosure of rebates will be made, and open-ended any other information necessary for the fiduciary to consider the reasonableness of the contract. But again, complying with HIPAA's protected health information restrictions. The audit rules, these are actually, something that I think plan sponsors and employers will welcome. The records of rebates need to be available for audit at least once per year. That's a term that we see currently, but it will be good for entities that have a little bit less bargaining power to be able to ensure that they are getting access to be able to do those audits. Rebate aggregators or purchasing entities have to remit rebates to the entity providing PBM services, PBM, within 45 days after the end of the quarter. This is an interesting provision because this provision is going to be, this is addressing a contract between the PBM and the rebate aggregator. But the plan sponsor that's entering into the contract to the PBM, they're not part of that contract with the rebate aggregator. So how could the plan sponsor ever know if this term is being violated? How could they enforce it? Because they're not a party to that contract between the rebate aggregator and the PBM. It's a nice thought. We'll see how it actually works out. Also, the TPA of a group health plan or covered service provider does need to make rebate contracts with rebate aggregators with available for audit by the plan. That might be something that could help answer previous questions. John mentioned before that there are restrictions on providing information to the general public. It's a similar topic here. Audits can require reasonable restrictions as the Department of Labor considers on confidentiality. So redisclosure of contracts and use of information for unrelated purposes can be prohibited. And then audits would be performed by an auditor selected by the plan fiduciary, generally probably the employer plan sponsor. This might be something that requires additional documentation in order to protect the employer plan sponsor to show that they made their selection of the auditor as the responsible plan fiduciary. And what was the process that was engaged in with respect to the selection of that plan auditor. Another provision that might be that it does make some sense with respect to limiting conflicts of interest, but payments for these audits can't be provided by the entity providing the PBM services. This is a structure that we do see currently. Plan sponsors like to save money, and this is a way to save money on audits, but it will be prohibited. A question that might be addressed in future guidance is if the auditor and the PBM have an unrelated relationship, how would that be distinguished from this prohibition? And then other payments, contracts can allow reasonable payments to PBMs for bona fide, so genuine services using a fee structure that is not otherwise described here. But the fees need to be transparent and quantifiable to the health plan. So this, could provide some wiggle room here for other services, but in general, the government is looking to rein in the contracting process, rein in these PBM contracts, and make them much more digestible and standardized, and make the fees, as plain vanilla as possible. So now I'm going to turn it back over to John, and he's going to wrap up the CAA 2026 discussion for us, and then he'll move on and talk about what we're looking at with respect to proposed regulations that came out at the end of January.
Sounds good. Thanks, Katie. Yeah, in terms of quick wrap up here, and I'll kind of move quickly through the rest of the slides here too, especially because the things when we talk about are more on the proposed side of the things. CA 2026 wrap up. Again, there's a lot of moving pieces here. It's kind of overwhelming, to be honest. There are certain things which are not happening. The CA 2026 does not make PBMs or TPAs fiduciaries. CA 2026 does not mandate rebates at the point of sale. Now, I talked about the ESI settlement, which does have some changes here, like on point of sale and spread pricing. So we'll see where that goes. CA does not prohibit the use of related entities like PBM-owned mail order and specialty pharmacies. Again, more disclosure about the fact that there is that relationship, but not a specific kind of hard stop there. So again, a lot of moving pieces. We'll see where all that goes. I've already raised some of these other issues. Will plan sponsors request that their PBMs implement these disclosures early? Would PBMs be prepared to do so? There's a lot going on here. I don't know, honestly, if PBMs could, just flip a switch and start reporting this tomorrow. My guess is no. It'll take some ramp up some lead time here. What are plan sponsors going to do with all this information? Contract updates. I expect that contracts will have to be updated, as Katie talked about. With these new prohibited transaction rules, really, it's kind of almost an immediate effective date. We may need some immediate provisions, immediate actions for any kind of, extension, renewal, new contract, things like that. So we do anticipate that plan sponsors are going to ask PBMs for assistance with some of this, assistance with the reports, other things, put that into the contract. Are PBMs going to charge extra for this? Will PBMs try to make up for some of the lost revenue that they might be experiencing? And how are plan enrollees going to act? Are they going to ask for additional information, or will their eyes just sort of glaze over and they'll say, okay, it's great that I have the right, but I'm never going to assert the right to see my own medical claim information. All right, let's jump ahead to the proposed PBM disclosure regulations. So again, totally different topic. Our last topic, the fourth of four topics. On January 30th, 2026, the DOL released proposed regulations to increase disclosures made by the PBMs. So again, same kind of concept. We keep kind of hammering on it. Now it's kind of another time that we're talking about this here in the same webinar, even though it's technically a different rule. That's why we're going to cover it here quickly. Like the CAA, this regulation is based upon the ERISA's prohibited transaction rules, basically saying that if you are a covered service provider, a CSP, and or an affiliate of it, and if you are receiving at least $1,000 in compensation directly or indirectly, and if you provide pharmacy benefit management services or advice, recommendations, or referrals related to it, then you're going to have to comply with these rules. So in general, PBMs are certainly going to get paid at least $1,000. They're going to be subject to this. That additional provision at the bottom, again, may also drag in some additional entities, like perhaps some additional consultants, perhaps. Pharmacy benefit management services mean services necessary for the management of the prescription drug plan. Doesn't matter if you call yourself a PBM, if you look like a PBM, if you act like a PBM, you're going to be subject to this rule. Includes typical actions like processing and paying prescription drug claims, adjudicating appeals. Also includes record keeping related to the covered plan's prescription drug benefits. One question in my mind is whether that would include an eligibility vendor. Many plan sponsors have eligibility vendors who really don't process any claims, but they might keep track of who's eligible for the prescription drug plan. Will those entities be covered or not? I think is an open issue. List the information that has to be provided by the CSP to the plan fiduciary. We're going to kind of walk through that here. In general, it's supposed to be provided in advance of the date on which the contract is entered into, extended or renewed. Generally 30 days for any kind of extension or renewal. Not quite clear what the time period is for an initial contract in terms of advance, so that's a little bit unclear. What has to be disclosed by the PBM? Services. What is the PBM doing? The compensation on a quarterly basis, the payments from the plan or plan sponsor on behalf of the plan. Manufacturer payments. So again, that's going to have to be part of this disclosure here, including the amount that it gets passed on to the plan versus the amount that the PBM retains. Spread compensation. We talked about spread compensation before, and again, it's going to have to be disclosed on a quarterly basis in terms of what the PBM expects to receive. Copay clawbacks. Let's spend a second on this one. So again, I know it's come up a little bit in the past. Copay clawbacks, the amount that is expected to be recouped from the pharmacy by the PBM. And what do we mean here? It's kind of the difference between the co-payment or co-insurance amount paid to the pharmacy by the plan enrollee and the reimbursement to the pharmacy. So let's suppose that Ed, a hypothetical employee, is covered by your prescription drug plan. Ed goes in for a generic drug to his local pharmacy. The cost is $15. but the pharmacy has and the PBM have cut a deal where the pharmacy only gets to keep $5. So when Ed reaches into his wallet and pays the $15, he's sort of overpaid by $10. The PBM may have a provision saying that pharmacy, you need to send that $10 back to us, and then they keep it as additional compensation. So that's this copay clawback compensation. Price protections. There could be some inflation protection or price protection agreements that the PBM has with a drug manufacturer or other party. And again, they could be receiving compensation in that way. That has to be disclosed, including what goes back to the plan versus what they keep. If there's a provision for compensation upon termination of the contract, that also has to be disclosed. In addition, all other compensation that the PBM expects to receive on a quarterly basis in connection with the contract has to be disclosed, along with who's paying them that compensation, the services related to the compensation, and the general arrangement that is leading to the compensation. Formulary placement incentives. It is possible that the PBM has a contract with a drug manufacturer, and the drug manufacturer may say, "Hey, put our drug on the employer's formulary so that there's an incentive for the PBM to do that." Now they're going to have to be disclosing that and how that incentive may affect the services, how it is aligned or perhaps not aligned with the interest of the plan and its participants and beneficiaries. And for drugs on a formulary where the PBM reasonably expects to receive any payments by the manufacturer or aggregator, if the dollar amounts are not passed through the plan, you have to identify, PBM has to identify reasonably available therapeutic equivalent alternatives and the reasons for omitting them. In addition, if the PBM has authority to modify the formulary, they have to explain the reasons for retaining that authority, the expected frequency of changes, and if they make a change and if that impacts their compensation, they have to disclose it to the plan fiduciary. Drug pricing methodology, the net cost of the plan of each drug in the formulary for each channel, retail, mail order, etc. Statement of fiduciary status, the PBM has to describe whether it provides any services as a fiduciary and whether they have any activity or policy that may create a conflict of interest. Whether, for example, if they have a drug substitution policy or step therapy or fail first protocols that may generate additional manufacturer rebates or other revenue to them. Again, all that has to be disclosed. Brokers and consultants. Again, the DWELs we talked about before in the CAA context is also concerned in this PBM context about brokers and consultants who may receive payments from parties that they're recommending. They note that it can create a high potential for conflicts of interest that warrant disclosure. So it looks like anyone who is a broker that's an affiliate of a PBM has to disclose that, or this information has to be disclosed. Doesn't look like it applies to other types of brokers and consultants. So this is a little bit more narrow, I think, than the other broker disclosure we talked about before. Audit rights, the PBM has to note that the plan has right to audit. Summary report. So again, a lot of information, but then there's so much information that the idea is, hey, let's summarize it. So the PBM has to disclose to the plan fiduciary in writing the following summary information on a semi-annual basis. All direct compensation that it received, all payments made by manufacturers and aggregators, the spread compensation at issue, copay clawback compensation on a quarterly basis, price protection compensation, other compensation not noted above, overages. So if the previous estimate that the PBM provided to you was off by a material amount, so basically 5% or more, the PBM has to explain, okay, here's what happened. There was a change in how much the manufacturers are paying us. We have to kind of explain why there was this differential, basically. The summary report also has to talk about the plan's right to audit and catch-all information. If there's additional information that the plan fiduciary needs from a legal perspective, like Form 5500 reporting, has to be included in there too. Audit rights. Again, we've talked about audits. Same concept here coming up in regard to the PBM disclosure rules. The PBM disclosure rules here say that the plan fiduciary can audit the PBM for the accuracy of these disclosures that are made to comply with these rules. Plan fiduciary has the right to select the auditor. The CSP, the PBM cannot select it. Unclear if they can influence it or if they could kind of blackball people. Maybe some auditors want to work on a commission basis where if they discover errors or things like that, then they get to keep it. PBMs and TPAs are not usually very happy about that kind of commission-based auditor. So it's a little bit unclear, I think, in terms of whether that would be allowed or not. Information that has to be produced on audit includes contracts with the retail pharmacies and drug manufacturers. Plan is going to bear the costs related to the selection and auditor costs. The CSP has to confirm receipt of a request for audit within 10 days. The PBM cannot impose conditions that restrict the plan's right to conduct the audit. So again, very, very pro plan sponsor in terms of a lot of these rules here. The CSP, the PBM, is responsible for providing to the auditor all records, data, et cetera, if owned or held by an affiliate or agent or subcontractor. The information that the PBM provides has to be clear, concise, free of misrepresentations, with enough specificity to permit the evaluation of the reasonableness of the contract. No generic industry terms, no jargon, no legalese, et cetera, et cetera. Compensation must be expressed as a monetary amount, like $1,000, may be estimated if the actual amount is not reasonably ascertainable. If requested by a plan fiduciary, it must be provided in machine readable format, and drugs have to use kind of an industry standard term, not just a term that the PBM has created. Confidentiality agreements. The PBM cannot impose restrictions on the covered plan's use of disclosures required under the regulations. That's kind of phrased a little bit awkwardly, honestly, but it does look like the plan fiduciary will be able to provide the information to its vendors to analyze the data that the PBM has provided. If there's an error by the PBM, it has to be corrected as soon as practicable, but not later than 30 days within the PBM becoming aware of the error. So if it gave bad information, it needs to provide kind of a correction within 30 days. Exemptions for plan fiduciaries. Let's suppose that your PBM fails to meet these requirements. Are you liable as a plan fiduciary? You're not if these conditions are satisfied. First, you did not know about the failure and you reasonably believe that the requirements had been satisfied. Probably want a contract in place that says, PBM, you will provide the following information. If you become aware of an error, you'll correct it, you'll notify us, things like that. So again, fiduciaries are going to want that kind of protection there. Upon discovering the error, the fiduciary requests in writing that the PBM correct the error. If the PBM fails to satisfy that within 90 days, the fiduciary has to notify the Department of Labor. So again, you have almost an obligation, not quite an obligation, but almost an obligation if you want to protect yourself to tell the DOL, hey, my PBM, I believe, is failing to meet these requirements. Whole laundry list of information to include in there, the name of the plan, whether you're still providing services, things like that. If at the end of the day you still, think that they have not corrected their error, then within 90 days, the fiduciary shall determine whether to terminate or continue the contract consistent with ERISA's prudence standards. Plan sponsors, again, are going to have to build that into their contracts. You're going to want that out where if you truly believe that they have violated the contract and they have not fixed it, you're going to want to have a provision in there that sort of mirrors it. Related question. That's a lot, but that's all specific to PBMs, generally speaking. Our plan sponsor is going to take those same concepts and try and build them into the contracts for every other health plan vendor that's out there, TPAs, broker, consultants. And how will they react? Will they say, well, we don't have to comply with that because that's a PBM obligation, not a TPA obligation, not a broker obligation, not a consultant obligation? I don't know. I really don't know how the industry is going to react in that context. Again, not technically required under these rules, so we'll see. Other sort of action steps here. That was a lot. I mean, Katie and I really threw a lot at you, not just on the proposed regs, but everything else. Think about this, kind of work through it, create procedures to follow, do it kind of bullet point. Okay, how are we handling this? How are we handling that? For a client, I put together a 60-page chart of all these kind of different obligations, and we're kind of working through how they're going to handle, each of these different things. So there's a lot out there in terms of trying to summarize it and take action steps here. Our advice, though, is don't ignore it. You should take this seriously. A lot of these implicate plan fiduciary obligations. in terms of the effective date of these regulations, they seem to be on a fast track. If I had to guess why, my guess is that the coming up before the midterms, the political parties, this is kind of a Republican initiative here. The Republicans probably want to be able to say, hey, we're helping to make drug prices more affordable. How are we doing that? Well, we issued these, new regulations that are going to make prescription drug costs affordable. So my guess is that the regulators want to finalize these proposed regulations in the coming months. I thought that they would probably get it done by April or May. There's some new guidance from last week indicating that the effective date may slip a little bit. They kind of extended the time period for comments to be provided from March 31st to April 15th. That suggests to me it's going to take them a good amount of time to weave in the CA 2026 stuff. So instead of it being effective July 1, 2026, if I had to go out on a limb, I'm thinking 1/1/2027, maybe November 1, 2026, just so they can squeeze it in before the midterms. I don't know. We'll see. All right. But we'll have a couple minutes here. I checked previously for questions. I didn't see any questions previously. Brian, Katie, are you guys seeing anything? I'm kind of in a view where it's hard for me to see it right now.
Yep, no questions just yet. So if anybody still remaining on the webinar here has any questions, please just submit them either through the Q&A feature or the chat. And thank you everyone though for joining us today.
Yeah. Yeah, let me just throw out one question that I know Katie and I have had some discussions on. Katie, what do you think would be a good idea if a plan sponsor gets in a contract right now, which is covered by one of these ERISA prohibited transaction rules? Is our advice to just, sign it, who cares? Or what do you think they should be doing here, I guess?
Yeah, so we have been advising clients to be proactive with respect to these fee disclosure obligations. And given that at this moment it looks like it's effective now, and it could, if you don't ask for it and don't get it, there could be it could be come back to haunt you. There could be ramifications, because under ERISA, by not getting this disclosure when you need it under the law, that could make the contract not quote unquote reasonable, and therefore be a prohibited transaction. So we are advising clients to be proactive, to say, if there is a contract in process or renewal in process, or even something that came out, you had signed something on February 5th, uh, it would look good to reach back out and say, hey, this law came out on February 3rd. Could you get this disclosure over to us? We want to make sure that we're doing the best we can here with respect to compliance. I
Yeah.
do see a couple of questions in the chat now.
Yes, yeah. So just so everybody, all of our attendees who are still on the call here, we did receive a question on whether or not a recording of today's session would be available or copies of the deck. We will be sending out follow-up communications after today that will have all that for everyone here. So you guys will receive that information from us.
Yeah, and following up on that, it's again, keep in mind the scope. I was working with a client. They had a dental plan renewal, network renewal, effective March 1, 2026. Dental does seem to be covered. It's such a small benefit that people don't tend to think about it, but again, I think it's covered. So we've reached out to the dental network provider to see if they can disclose some of this compensation. So really broad impact, and as Katie noted, kind of an immediate one. Um, yeah, unfortunately.
Yeah. Typically, so the last time this happened with brokers and consultants, the Department of Labor, or excuse me, the statute provided for a delayed effective date, uh, which obviously gave time to figure out, like, what exactly do we need to ask for, and then gave service providers time to figure out what might this disclosure look like. And just based on what we have at this moment, that's not the case for these for contracts for basically any sort of health related benefit uh, that, it looks like it went into effect on February 3rd. And we have not heard anything from, no non-enforcement policies, no clarifications. So we're just still proceeding as if, that is the law, and that's what the expectation is at this moment.